is yours.
So thank you very much for your nice presentation and for inviting me in this important occasion. So today's topic is antimicrobial therapeutic drug monitoring in hematological patients. I organized the speech in these three main sections. I will give you some examples of optimizing the use of beta-lactam, which are the most frequently used antimicrobials in hospitals, mainly against gram-negative infections. And then I will jump to giving an example on the importance of optimizing the use by means of TDM for anti-gram-positive agents, in particular for daptomycin. And the last topic is how to appropriately manage antifungal triazole drug-drug interaction, mainly with immunosuppressive drugs. So starting from the first topic, optimizing the use of beta-lactams. So how can we define when an antimicrobial therapy is adequate in patients with severe infections, so in critical ill patients, but also in hematological patients that in some way may be considered similar to critically ill patients? So the first point is that the antimicrobial should be initiated as soon as possible when an infection is suspected. The second point is that the antimicrobial should cover, of course, should be active against the suspected or documented pathogen. So the antimicrobial spectrum should be taken into account. This is what the infectious diseases and you do when you select an antimicrobial. But the third point of appropriateness of antimicrobial therapy is related to antimicrobial dosing. And in terms of optimizing the dose, we should have in mind to aim these 3 points. The first is, of course, maximizing antimicrobial killing, which is the first of our topics. The second topic is to minimize the development of multi-drug resistance, especially in Europe, in the southern part of Europe. This is an important topic, and so the use of antimicrobials should target this aim. And the third part is avoid concentration-related adverse drug events reaction, if possible. So how can we imagine the treatment of infection in a modern way? This image resembles a puzzle in which different pieces should put together, should integrate to address correctly antimicrobial agent. The first, of course, is the choice of the antibiotic. But the site of infection should also be considered, because treating bloodstream infection is different from treating a pneumonia or for treating an infection in the central nervous system. The third part is the patient pathophysiology, and this is a very interesting part to consider. For instance, a patient with renal insufficiency, a patient with augmented renal function, a patient with drug-drug interaction should respond differently, and the antibiotic should behave differently, taking into account this patient own characteristics. And the fourth part is the pathogen susceptibility to the antibiotic, which is resumed by the MIC, the minimum inhibitory concentration, a number that tells us how the selected pathogen is susceptible to that antibiotic. So all these 4 parts should integrate together and should be considered at the same level. Just to recall some PK/PD property from the traditional pharmacology of antimicrobial agents. So antimicrobial agents could be divided into 2 groups in terms of their way they kill pathogens. And so there are concentration-dependent antibiotic, for instance, aminoglycoside, for instance, daptomycin, for instance, fluoroquinolones, in which the goal, the pharmacodynamic goal, is to maximize the ratio between the maximal concentration and the MIC of the pathogen, and this is why these agents are given once daily. The other group of antibiotic is the so-called time-dependent antibiotic, in which beta-lactams, of course, are the main representative. And the killing mechanism here is completely different. It depends on how long the antibiotic concentration remain above the minimum immunity concentration of the pathogen during the dosing interval. And so, for example, all the beta-lactams, so penicillins, cephalosporin, carbapenems, behave in this way. And this is why the correct way to administer this drug is by multiple dosing up to continuous infusion. So this is the basic of the PK/PD of antibiotics. So when looking at the clinical guidelines that may support clinician in properly integrate PK/PD principle in clinical practice, well, I give you some clues about what one of the most important recently published position paper tells us about which PK/PD target of efficacy should be targeted in patients with severe infection. And if we look to beta-lactams, well, the target of efficacy for having a clinical efficacy are you can see here that the concentration be up to 100% times above, 100% times during the dosing interval above the MIC, which means that continuous infusion or extended or continuous infusion should be the correct way to administer these drugs. On the contrary, for daptomycin or fluoroquinolones, here you can see that the AUC over MIC, so other parameters, AUC over MIC, should be targeted, should be taken into account. So all these PK/PD parameters are well studied, well established, and should be integrated in our clinical decision. So for beta-lactams, there are recommendations for TDM. So the panel of experts stated that TDM for beta-lactam should be advocated, should be recommended, and the way to monitor concentration is by sampling trough concentration if these drugs are administered by extended infusion with one sample just before the scheduled dose. Or if the drug is administered by continuous infusion, you monitor the steady state concentration. And here you can sample patient anytime during infusion because the concentration is a flat line. This graph here, image here represents the difference in terms of concentration depending on the way antimicrobial are administered. So if we imagine that this dashed line here is the MIC of the pathogen and drug concentration should be above this MIC level, the MIC threshold, you can see that by administering the same dose of the same antibiotic by intermittent infusion, you have a time during the interval where concentration fall below this level. And so here, for half the dosing interval, antibiotic is ineffective. When you prolong dose, so by administering extended infusion, you can see that the period in which concentration fall below this efficacy threshold reduces, and so the efficacy may increase. And when you administer antibiotic by continuous infusion, the red line, then if appropriately targeted above the MIC, you ensure your patient 100% of the concentration above the MIC, so a threshold of efficacy is already reached. And so this is the advantage of giving extended infusion or continuous infusion to your patient. You ameliorate the achievement of the PK/PD of efficacy, target of efficacy. And so in order to see, to give you some, some proof of efficacy of continuous infusion, in a patient with febrile neutropenia, hematological patient with febrile neutropenia. Some years ago, we conducted a monocentric experience on 75 patients. You can see here having more than half acute myeloid leukemia, and 42% of them received an allogenic hematopoietic stem cell transplantation. And if we look at the multivariate analysis, the factors which affected at regression analysis all-cause mortality, well, two factors, having received a history of transplantation and having an augmented renal function are factors that associate negatively with all-cause mortality. In particular, augmented renal function means a creatinine clearance above 130, which is a condition oftentimes observed in patients with sepsis, septic shock, but also in patients with acute myeloid leukemia. So be aware of your patient, of the renal function of your patient, because oftentimes that augmented renal function may be present even in a patient with oncohematological disease, and this may affect the achievement of PK/PD, target of attainment, because concentration may decrease, and also with an effect also on clinical outcome. By giving meropenem, in this case, by continuous infusion in this population, here you can see in the slide the median dose of 1 gram every 8 hours, and the concentration achieved here of 12.7 milligram per liter as median concentration. We observed a cure rate of 89%, but the most interesting thing is that we observed after meropenem treatment that no patient remained colonized by carbapenem-resistant Enterobacterales. So the colonization after treatment was equal to 0. Unfortunately, there are no other reports that confirm or do not confirm our observation, but the clue is interesting, suggesting that by optimizing drug administration, by using continuous infusion, then the effect on colonization by multi-drug resistant pathogens may be positively affected. So we can go a bit farther by identifying through a statistical method, which is one of the most diffused pharmacological methods nowadays in clinical pharmacology, which is population pharmacokinetics. We can identify which doses of meropenem could be administered according to patient renal function in order to attain the PK/PD, the optimal PK/PD target of efficacy, which is having, as I told you, a concentration of in plasma above 1 to 4 times pathogen MIC. And here you can see from this graph that, for instance, in a patient having creatinine clearance between 50 and 89 milliliter per minute, then a total daily drug dose of 3 grams by continuous infusion every 24 hours achieve more than 90%, with a more than 90% probability, the optimal PK/PD target of efficacy. Of course, if creatinine clearance increases, so for instance, between 90 and 130, then the optimal dose is 4 grams by continuous infusion daily. And if patient have creatinine clearance augmented renal function, meaning creatinine clearance greater than 130, then the proper dose is 5 grams daily by continuous infusion. Recall that for meropenem, you have to reconstitute the solution every 6 hours because the drug is unstable above 6 to 8 hours. So, for instance, 4 grams daily means 1 gram every 6 hours with infusion of 6 hours to obtain continuous infusion. Very recently, so at the beginning of this year, a clinical trial called Beetle trial was published in Clinical Microbiology Infection. What this trial told us, well, the author randomized, made a comparison between extended infusion and intermittent infusion of beta-lactam antibiotics. There were meropenem, piperacillin, tazobactam, and cefepime. They randomized, the primary endpoint was treatment success at 7 days in terms of the effervescent without modifying the antibiotic treatment. And then secondary endpoints, they included adverse event and 30-day mortality. What they found is that essentially there was no difference between extended infusion and intermittent infusion in terms of achieving these outcomes. However, the sample size was not so big, 77 per patient on extended infusion, 73 on intermittent infusion. There was no assessment of, no reporting of drug concentration, and there was no reporting of pathogen MIC. So this author concluded that there was no statistically difference between the two groups. But I invite you to go a bit deeper from this, from this observation, and what extending infusion or continuous infusion offer as an advantage in this patient is well documented if we change for a second the patient population, and if we consider critical ill patient where the magnitude of the literature is much bigger than in oncohematological patient, we observe even recently interesting things. And I just tell you in a few minutes what the recent literature in this population tells about confronting prolonged versus intermittent infusion. This is a recent meta-analysis including 17 clinical trials of more than 9,000 patients, and they conclude, they found that there is a significant association in terms of clinical cure favoring prolonged infusion over intermittent infusion. Prolonged infusion is associated with an odds ratio, here you can see, of 0.86, favoring prolonged infusion in terms of clinical outcome. And we also recently conducted a meta-analysis including 21 studies in order to search if attaining an aggressive versus a conservative PKPD target for beta-lactams may be an advantage. What means by aggressive PKPD target? Aggressive PKPD target for beta-lactam means achieving a ratio between concentration and MIC above 4 times the MIC. So the concentration of beta-lactams in plasma above 4 times the MIC. And the interesting aspect is that if we target this aggressive PKPD target, so a CSS over MIC above 4, there is a benefit of clinical cure, but there is also a benefit in the prevention of resistance occurrence. So optimizing the use of beta-lactam may be also effective in terms of antimicrobial killing, but also in terms of preventing the resistance occurrence. This should be, of course, demonstrated also in oncohematological patients, but the bases are, of course, very suggestive of this for this aspect. So we can see a shift from preclinical PKPD target attainment to what is necessary when treating patients. So traditional PKPD target are those in the red box. So concentration above the MIC between 40 and 70% of the time within the dosing interval. This is what is the preclinical target, and how antimicrobials are currently tested nowadays. What we observe in the clinic is that this target is not sufficient. So we have to target a more aggressive PKPD threshold, which is at least 100% of the time, at least concentration above the MIC for the entire period for the entire dosing interval, the optimal way is 4 times the threshold. So a ratio between CSS over MIC of greater than 4. This is, of course, this applies, of course, also for the newer beta-lactams. So, for example, for ceftazidime avibactam. For ceftazidime avibactam, the need for TDM is advocated by observing the fact that the concentration of ceftazidime over avibactam changes across classes of renal function, meaning that patients in the higher range of renal function, so greater than 120, greater than 130, may have less avibactam that it currently needed for antibiotic efficacy. And you can see here the changing in the ratio of ceftazidime over avibactam. So the problem with ceftazidime-avibactam and also for piperacillin tazobactam is if for achieving a proper treatment and TDM is maybe helpful in order to address even the concentration of ceftazidime and avibactam. And you can see here from a recent population PK analysis that we did that at the clinical breakpoint of enterobacterales against ceftazidime-avibactam, which is 8 milligram per liter on the right-hand side of the slide in the red box, you can see that achieving a proper concentration of avibactam is hard with the standard dosages. Here you can see that 90% of the probability is never reached with the standard dosages. So this means that optimizing the dose in the specific patient with this antibiotic is going to become an even more important topic in times as in our times when antimicrobial resistance are raising. So, changing gear to the second topic, so antimicrobial, optimizing dose in antimicrobial against gram-positive pathogens, I give you an example for daptomycin. So this is a population pharmacokinetic analysis that we did some years ago on 30 patients, which were sampled extensively. This patient had acute myeloid leukemia, 60% of them, and half of them were infected from bloodstream infection. The problem here is which dose should I give of daptomycin to this patient? You know that during the year there was an increasing tendency to using higher dose, 8, 10 milligram per kilogram of daptomycin, but on which basis I select 6, 8, 9, 10, or even more, 12? Well, the response may be observed in the selection of which factor, on the combination of which factor may affect daptomycin clearance. So in this 30 patient with hematological malignancy, we found that 3 covariates or 3 factors affect daptomycin clearance in a statistical way, in a significant statistical way, which are creatinine clearance, albumin concentration, and having or having not an acute myeloid leukemia. So the combination of these 3 covariates may estimate drug clearance and in turn help us to identify the optimal dosages in terms of achieving a PK/PD target of efficacy, which is, I told you in the first slides, an AUC over MIC greater than a certain number, which is more than 1,000 of AUC. So by combining these 3 scenarios, so creatinine clearance, albumin concentration, and having or not acute myeloid leukemia, we, in order to target this AUC over MIC target, we can build this tree. So in patient with, for instance, in patient without acute myeloid leukemia, with a lymphoma or other hematological disease, having a creatinine clearance between 50 and 100, and an albumin concentration between 2.6 and 4.5, so hypobilinemia or non-severe. So the proper dose should be between 6 and 8 milligram per kilogram daily. So even a dose of 6 milligrams per kilo may suffice in order to target this target of efficacy for bacteremia against Staphylococcus aureus. On the contrary, we can take the last part of the slide. So a patient with acute myeloid leukemia with maybe an augmented renal function, a severe hypoalbuminemia between 15 and 25 grams per liter, so a dose up to 12 or even more milligrams per kilogram daily may be selected and administered to these patients. So by combining all this characteristic, this physiopathological characteristic, we can optimize properly the dose of daptomycin. Of course, TDM of daptomycin should help our clinical decision, but as far as I know, it's not so diffuse in clinical practice. The third topic is triazole in drug-drug interaction. You all know that voriconazole is an antifungal which is characterized by high inter-individual pharmacokinetic variance due to several reasons. The first is the genetic pattern that may be responsible for different pattern of elimination. So CYP3A4, CYP2C9, CYP2C19 are all enzymes that may metabolize voriconazole in different rates according to how many and how efficiently this enzyme may work based on pharmacogenetics determinants. The second aspect is drug-drug interaction that may block or enhance the activity of this enzyme. And the third aspect is inflammation, which is a quite recently achievement. We observed that patients with a CRP, with higher CRP, so 15, 20, 50 milligram per liter, may experience higher concentration of voriconazole because CRP or inflammation act as an inhibiting drug, we can say. So for voriconazole, there is an established target of trough concentration between 1 and 5.5 milligram per liter in blood. And so targeting drug concentration within this range is fundamental in order to avoid toxicity and inefficacy. Here I show you how variable is trough concentration of voriconazole. This is a report, one, as far as I know, the biggest report we have, accounting for more than 14,000 concentration taken from a laboratory assessment in the United States more than 10 years ago. And this work gives you a perfect picture of the situation. So 50% of the patient, you should expect that 50% of the patient are outside therapeutic range when using standard doses. So 4 milligrams per kilogram every 12 hours. And another 50% is in range. So half of the patient you use standard dose, you administer standard dose, are out of the range for the reason I told you. Voriconazole is, of course, first-line treatment in the central nervous system aspergillosis. Therapeutic drug monitoring is recommended when using this drug in this clinical scenario, targeting 2 to 5, so the trough concentration, the lower level should be a bit higher in serum, and liposomal amphotericin B is an alternative to voriconazole, when voriconazole could not be used simply because liposomal amphotericin B penetrates less well than voriconazole in the brain. What can we say about posaconazole, which is a typical hematological antifungal drug? So which is the problem, when using posaconazole? The problem for posaconazole is absorption. Essentially is absorption, which was partially solved passing from syrup to tablets. Here you can see a small study we did some years ago on 66 patients affected mainly by acute myeloid leukemia and acute lymphatic leukemia. which were the factors that at regression analysis impacted the most on trough concentration of posaconazole, co-treatment with proton pump inhibitors, and co-treatment with steroids. All these drugs act by reducing drug concentration. One, because proton pump inhibitor, because it neutralizes the acidic environment. Posaconazole needs an acidic environment in the stomach to be absorbed, and the steroids by a sort of inducing effect on posaconazole administration. So be aware that the administration of this, the co-medication with these two drugs, proton pump inhibitor and steroids, may significantly decrease your concentration in your patient. Of course, it depends also on the dose of proton pump inhibitors. The second problem more recently highlighted on posaconazole is that posaconazole may block some enzymes on aldosterone, on the cascade to aldosterone production, and all of this hence in giving a pseudo hyperaldosteronism in your patient, which means that your potassium level may decrease in your patient. Last year, I recall a patient with 1.5 of potassium due to, here in Bologna, due to posaconazole. And in the same time, the sodium retention and the water retention may increase hypertension. So this happens this is a concentration dependent effect, which happens with posaconazole concentration above 3.5, 4 milligram per liter, which honestly doesn't occur so frequently, but you have to, of course, consider this symptoms, this observation, if your patient is taking posaconazole, and maybe doing a TDM of posaconazole may help in deciphering the reason why you may observe this unexpected symptoms. With isavuconazole, all this problem disappears. Isavuconazole concentration in plasma are much more stable. It is a longer half-life, and the need for TDM is less compelling than for voriconazole and posaconazole. Here in this graph, you can see median isavuconazole concentration that are all above, are all above the threshold of efficacy, which is 1, and all below, or more than 90% below the supposed threshold of toxicity, which is 5, which is associated with some mild gastrointestinal toxic effect. So with posaconazole, the risk of drug-drug interaction is less compelling. In order to give you some magnitude of the extension of the interaction between triazole and immunosuppressant, I would like to focus on this table, which reports the fold increase in AUC of the immunosuppressant, here cyclosporin, sirolimus, or tacrolimus, when isavuconazole, voriconazole, or posaconazole are used in this patient, so in a patient. So, for example, with the voriconazole, you should expect an increase in cyclosporin exposure of 1.7-fold with respect to a patient which is not taking voriconazole. Look to sirolimus, for instance. Sirolimus voriconazole is a dreadful interaction because sirolimus AUC increases up to 11-fold when voriconazole is present. So the only way to overcome this problem is by doing TDM. So TDM of both agents, of immunosuppressant and of the triazole. Another way to look to this problem this was one of the first very interesting review that appeared in 15 years ago by Dodds Haslage, which addressed this issue. So in another way, so for instance, when you administer cyclosporin and voriconazole, you should reduce the dose of cyclosporin by 50%, of tacrolimus by 66%, of sirolimus by 90%. With posaconazole, dose reduction is milder, but I mean, it is however significant. So reduction of 30% of cyclosporin dose when administered posaconazole, between 75 and 80% when administered tacrolimus, and with sirolimus is not recommended. So again, the management of drug-drug interaction with TDM is barely impossible without TDM, of course. Another important thing to remember is that dose reduction of the immunosuppressant should be prompt when starting the azole treatment, because this interaction is an inhibitory interaction. So the triazole, the antifungal, act immediately on the cytochromes. And so those reductions should be prompt in terms of few hours when these two drugs are considered. So the way to properly address this interaction and to address, for instance, beta-lactams antibiotic is, as I told you, with TDM. TDM is in itself is the determination of concentration in plasma, but this concentration should be properly interpreted. This is the key. If I give you a number to clinical infectious disease, to a hematologist, probably this number is not suggestive of modifying a dose. So the problem is that TDM should be coupled with a clinical interpretation, a clinical advice that inform, that guide physician on how to adjust drug dose. And this is what we do here in Bologna. So all the lab determination, the analytical determination is managed by the normal laboratory of analysis, our lab of analysis. Then drug concentration are put in an electronic intranet system, and clinical pharmacologists interpreted the drug concentration in light of all the characteristics that I told you before. So patient pathophysiology, microbiological characteristics, so DMIC, and patient data, of course. So the existence of drug-drug interaction, the daily dose, co-medication, and diagnosis, in order to provide the requesting physician clinical pharmacological advice on how to adjust drug dose back to applicant clinician within the same day, possibly, of infection. We did an analysis of our activity from 1 year activity in 2023, and at our unit were stratified by applying wards, so hematology, ICU, pediatrics, medicine, and surgery. And the most frequently analyzed antibiotics were piperacillin and meropenem, then linezolid. But what I want you to say is, even if the total number of advices were higher for the ICU and then followed by the medical ward, when normalizing this gross number, this total number, by 100 beds year, so by the number of beds within each ward in our hospital, it appears that hematology contributed the most in terms of burden of request, burden of needed for assessing properly drug concentration hospital-wide. So the impact of optimizing antibiotic, antimicrobials, antifungal in the hematology is fundamental. This is the last slide, which show you from the analysis I told you before, the impact of drug concentration at first TDM and at second TDM in hematology ward. Here you can see with colors the situation at first TDM. So at first TDM, for instance, there was a need for dose increase to voriconazole, ganciclovir, teicoplanin. There was a need for dose decrease of linezolid, and you can see that just from the second TDM on, all the main color was red, so it was green. So the situation get better. So this meaning that one TDM may make the difference in your patient in terms of adjusting drug concentration in order to attain the proper PK/PD target of efficacy. So if you can do 1 TDM may be enough for most of the situation to correct drug exposure and to ameliorate exposure in your patient. And I thank you for your attention.
Thank you very much, Dr. Cojuttiprovides, for your presentation. It was very detailed and very good overview of the strategies. Thank you very much for this. I want to ask you, our participants whether they have questions. Please let us know by raising the hand or dropping the message in the chat if you have them. I see no questions so far, no hands. It's okay. It means that everything was clear enough already. Let's wait maybe a couple of seconds. Okay. I guess then we can conclude the event. Thank you very much again, Dr. Cojuttiprovides. It was a pleasure to have you. And we will, of course, share the recorded webinar on the online, so then people can rewatch it. And if someone cannot join, they can see it as well. Thank you very much. Have a nice afternoon.
Thank you.
And good luck.
Thank you. Thank you. Have a nice day. Thank you.
Bye-bye.